No, my goal would be to make it smooth and easy.
Good morning. I'd like to welcome everyone here and open the August 17th meeting of GETAC. And the first item on the agenda is the approval of minutes.
I was here. They left me off. I was actually present at that meeting, and I want credit for my suffering.
Are there any other corrections to the minutes? I'll entertain a motion in a second.
So moved.
Second. All those in favor?
Aye.
All right, motion passes. Chair report and discussion. I have very little at this time. Most of the comments that I would have will be later on in the agenda. First thing I want to do is, per our strategic plan for the council, is to read our mission and vision statements. Our vision is a unified, comprehensive, and effective EMS and trauma system for a healthy, safe Texas. Our mission is to promote, develop, and maintain a comprehensive EMS trauma system that will meet the needs of all patients and that will raise the standards of community health care by implementing innovative techniques and systems for the delivery of emergency care for the entire population. I forgot to mention, if you'd set your iPads, cell phone, phasers, whatever on stun, so as not to disrupt the meeting, we'd appreciate it. And also, we'd like to thank TTAF, who's broadcasting the meeting again this morning with the control booth over here to my left. If they're looking at you strange or waving their hands, you're not close enough to the microphone, and it's real important we do that so it can be picked up on the internet. So please, when you're coming to the microphone in the public or council members, remember to pull that microphone in close like you like it. I've been reminded for all council members that we need to be shot after this meeting. Sorry, we need to have our pictures taken after this meeting. So if you just stick around after the meeting, we need to have our mug shots taken for the website. And the only other comment I have at this time is all of us work hard at trying to have a great trauma system, EMS system for the state of Texas. And I know that all of us on council truly appreciate all the effort that's put in by everyone, whether it's the Department of State Health Services or the committees or the RACs or all of the stakeholders that are actively involved. And so I just want to take one moment and say thank you to all of you for making this process move so well and so effectively. Even though we may disagree from time to time, we still have a lot of love and respect for each other, and I think that's what keeps this process going. So thank you. And that will end my comments, and we'll move right into Assistant Commissioner Perkins.
Good morning. Few things to tell you about today. Most of you may be aware that Mr. Cease, the Executive Commissioner of the Health and Human Services Commission, announced his retirement recently, effective the end of August. As well, the State Medicaid Director, Billy Milwee, is also retiring that same time, so that's kind of a 1-2 punch to Medicaid. They have announced the new Executive Commissioner. It is Dr. Kyle Janik, who used to be a senator from the Houston area. We have worked with Dr. Janik in my division over the years with ambulatory surgery center issues, as Oyster, a number of different issues. So he has some knowledge of our programs, and we look forward to welcoming him to his new position. The department's legislative appropriation request for fiscal year 14-15 has been entered into the legislative budget board system. It's probably not public yet, but it won't be very long before it's a public document on the LBB's website. For our division, we did basically base funding for the regulatory strategies. We did not request any new funding because of the cuts last time and the anticipation that there probably isn't a lot of, it's going to be a tough session. It's going to be a lot. They're coming in with a deficit that they've got to address in education as well as in Medicaid. So we decided it would not be a good thing to try to increase regulatory funds at this time. We did have to do a 10% schedule, a 10% reduction schedule. The department did not put any regulatory funds on that schedule, so we did not propose to cut any regulatory program funding at this point. However, we did have to put some of the trauma monies on there. About $15 million was put on for the 10% cut schedule. Does not mean that they will accept those cuts, and of course that's just a starting point for the legislature to start looking at what they're going to do. The next step will be a hearing. I believe it'll be the 22nd of September, but we will confirm that and get that out to everybody. The first hearing on our legislative appropriation request for our department, and it is combined, the governor's office, lieutenant governor's office, and leadership. And that is a public meeting, and people can come and make public comments at that hearing. So we'll get that information out to you. The other thing that I wanted to talk to you about, I've mentioned before that not only did we take a $16 million cut in general revenue to the regulatory strategies, but we also had a rider 59, put on our appropriation bill that directed the department and HHSC to look at all regulatory programs for the potential for raising or adding new fees, administrative efficiencies, and reducing the number of complaint investigations and inspections, routine inspections that we do where there would be the least risk to the public. My staff and I, my managers and I, worked starting in June to do kind of a self-assessment, really evaluate our statutory authority, what we have authority to do, what we don't, where we might start reducing things that would be less risky than others. We were already operating with risk matrices and making decisions on which complaints we would investigate and which routine inspections we would do, and we were already not doing to the level that we believed we needed to. So we're going to go down from there. A lot of people were surprised. They did not realize we weren't doing those things, and so we're going to go down from where we were. The Health and Human Services Commission hired a private consultant to evaluate the work that we did, as well as do their own evaluation and come up with a report for the regulatory strategies. There's a couple of ways you can provide input. We provided them with a list of all our stakeholder organizations and contact, and they've been having a series of calls with stakeholders, asking a series of questions like, how do you feel about having your fees raised? I think you can take a guess at the answer to that one. But there is also a survey on our website, and I really encourage everybody. We went out and let everybody know who was on GovDelivery about that survey. But if you are not getting those notices, it is on every one of our regulatory program websites, social work, EMS, and it says take the survey. And it is a series of questions. I don't remember what the format is, but it's fairly easy. It doesn't take that long to do. And it asks for, I want as many people to provide input on this issue as possible. The consultant group will be providing us some initial draft of their recommendations in early October, and ultimately a final report to the department in December, which we will evaluate and ultimately send some kind of report downtown early in the legislative session. I can say that many of the things that they're starting to say we need to be looking at, we have already started down the road to doing. Some of them relate to technology, And we don't disagree that we need mobile tablets to do inspections. We don't disagree that we need imaging so that we're not bringing in paper. We don't disagree with a lot of those things, but you also have to have the money and capital to be able to do it. But if an outside consultant puts that in a report, I think that will help us. So anyway, that's going on right now. Also, I've been talking to you guys the past couple of times about our relationship with the Texas Medical Board, and we are steadily, really where I wish we were 10 years ago. We had an all-day meeting with their chief, my staff had an all-day meeting with their chief investigative staff not very long ago, looking at cases, and really close to having an MOU between our two agencies, which would allow us to share more details of our investigations, which is a good thing. We're starting to work with them on other issues like narcotic treatment programs, et cetera. So I'm really, really happy with where we are with the relationship with the Texas Medical Board. We recently also had a collaboration with the Houston Public Health Department. Houston, that agency has an ordinance in relationship to ambulances, and so we did a joint event, and we're working to how we can share inspections between us so that we're not duplicating. Anywhere else that wants to do something like that, we're very open. We were able to find a large number of firms that weren't there, basically. We went to addresses and there was nothing there. And so trying to really get to this whole fraud issue, really targeted, Houston was able to give us information that helped us target our inspection so that we could look to where the concerns might be. And we have implemented some things like, I believe I mentioned this to you before, if we are made aware that a firm doesn't have a medical director and we have good enough evidence, then we can take action. So we're doing quite a bit to try to address the fraud issue from our side. There does have to be rule changes. I know that there's some discussion, and the medical board is also putting some rules out for public comment soon related to this issue. And I think that's it, unless you have any questions for me.
I just had one question. This may not be the right term, but the 10% in case you have to do cuts, that's part of the routine budget process, isn't it? Or is this something different than before?
Well, it's become routine. In the past, we've had a 2% schedule, we've had a 1.5%, we've had a 5%. The last couple of sessions, it's been 10%. Okay. It's 5% for each fiscal year. So it's really become a regular occurrence.
Okay. Thank you.
Kathy, I have one question. You mentioned 15 million out of trauma. Could you be more specific where you're talking about that coming from?
It's the 5111 account, the uncompensated trauma care account. So not tobacco, not the money that goes to the RACs or EMS. Although if 15 million comes out of 5111, since there's a percentage of that goes to the RACs and goes to EMS, there would be a reduction for them also. The other thing that will be in the LAR that we've discussed before is the balances in the dedicated fee accounts, and I think that y'all are that more legislators are becoming more vocal about the concerns about those, and you will be able to see in our LAR the balance in the 5111 account, which we believe, I think it's going to be around $400 million. And also in the EMS fee, the hospital licensing fee, and many of the other fees that I have that support my division.
Any other questions for Commissioner Perkins? All right, we'll now hear a report from Director Guerrero.
Good morning. Okay, for our trauma system, we currently have 259 designated trauma facilities, and we have 25 that are in active pursuit. Those that are in active pursuit have that 2-year window in which to become designated. For stroke, we now have 96 designated stroke facilities. 93 of those are primary. 3 are support stroke, and we have 1 additional application for support stroke in our office. For level 1, the comprehensive stroke facilities, we're at a point now where we are ready to proceed with designating those, the comprehensive level. The application will be available on our website on 9/1, and we will be accepting those applications through starting October 1st. By rule, the certification, the disease-specific certification for the Joint Commission is mentioned in our rule. We've done, the Stroke Committee actually did an analysis for us and compared the Joint Commission program to the DNV program, and they determined that they were comparable programs. So on our website, we will put information that we will accept either or certified as a comprehensive facility as our designation, for designation. This is very similar to what we do for the primary level stroke centers. If they are certified by DNV or the Joint Commission, we accept either one as a disease-specific certification. Any questions on this area? Okay. Moving on, in our office, we've had some significant staff turnover this summer. We currently have 2 new designation coordinators. Our 2 other coordinators went on to greener pastures, and that means they're still alive, but they're doing other things. Mike Murray and Patricia Ashton Garcia, if y'all would please stand. These folks have just joined us in the last month. They're both registered nurses. Mike comes to us with previous experience as a trauma designation coordinator. He's been out doing other things for a while. Patricia Ashton Garcia is a registered nurse with many years' experience, and she comes to us from DADS, where she was a case manager. Case management fits very well with designation coordinators, so we're pleased to have them. We have 1 open position now for a designation coordinator. It is posted, and we will be we are accepting applications now, and we'll be interviewing hopefully in a month or so. The RAC coordinator position is currently vacant. That individual received a promotion in our division, so she still works with us, but not in the position of RAC coordinator. We are in the process of going through applications and selecting persons for interview now. Any questions? Okay, we'll move on to our funding report. For our uncompensated trauma care fund, the 3588, we actually have $54 million that was in the appropriation that would go out to hospitals for uncompensated care. Now, you might remember that this year the way it's being distributed is a bit different than we've done in years past. For $26 million of that account was used to bring matching federal dollars down into the Medicaid program, and that has been distributed out to designated hospitals that participate in the standard dollar amount trauma add-on. So those funds have been going out to these hospitals throughout the year, and there are some 70 of our designated facilities that are participating in this program. The hospitals that do not participate through the SDA trauma add-on, we have already done the calculations for their uncompensated trauma care disbursement and have made that disbursement. We do have funds left over in the account. The reason being is that part of the program for the SDA says that those SDA hospitals will be held harmless. So in other words, the funding that they've received throughout the year, if it turns out that it is actually less than they would have received through our uncompensated trauma care grant, then we will make them whole. We would make up the difference. So we still have money sitting in that account. We will do a reconciliation with HHSC and true up the numbers to find out exactly what those hospitals would be paid through our uncompensated trauma care grant. That probably will not happen until later, after the end of this fiscal year. We don't know exactly that timeline yet. Any questions on that? That's condensed a lot of information smashed into a small amount of time. No? Okay. On the 9/11 and 11/31 monies to hospitals, we've distributed approximately $1 million. The 9/11, 11/31, and 3588 for RACs is 1.3. EMS was almost $3 million. For EIFs, we have funded 4 total, and we have a remaining balance of $853,000. This was a topic that we talked about at RAC chairs, because each year, or historically for about the past 3 years anyway, we've had a remaining balance in this EIF account. And what we do with those funds at the end of the year, they're distributed out to the hospitals through the formula that we use for uncompensated trauma care. We leave nothing in our accounts at the end of the year because it can impact our appropriations down the line. But what we talked about at RAC chairs is to try to utilize this money more effectively. We felt like that the folks that really need it probably don't realize that it's there and don't get the word to apply for it. This fund is available for EMS. It's also available to hospitals. And it is for extraordinary emergencies. So we're looking at something that would be a degradation of service in that area. So what we're going to do for is on a monthly basis, we're going to send a reminder to the RAC chair and the executive director of each RAC and tell them how much is remaining in that fund so that they can possibly identify services in their areas that could use this money and could actually apply for it. At the end of the year, those that have applied and have not been granted funding through this account, we relook at that to see if there's anybody that we could go back and fund potentially. Normally, those folks are the ones that are not funded through EIF are directed back to the local project grants. Normally, they're more appropriate projects for that. Any questions on this funding so far?
I had one question. That EIF funding that you're talking about, if there were, say, an EMS agency that was rural and blew the engine out of their ambulance and it's sitting there parked because they're trying to raise money or get money to fix that, would that be something that qualified for that?
Yes, it would.
Okay, thank you.
How quickly can they get it?
It's very quickly. Let me qualify. It depends on the circumstances. If they blow their engine because they didn't maintain their ambulance, okay, it's probably not going to get funded, okay? But if they've done what they've needed to do and they've gone through their other avenues in their area to get funding to repair their ambulance, we're kind of like the last resort, okay? It's quick. I mean, we can get money out to them in probably about a week.
Question.
And sometimes we've used this as a stopgap. So a bank may come in, or they're trying to get a loan or whatever. I mean, so there's many ways we can approach this in order to get that ambulance back in. But it really has to show a degradation of service. If they've got one that blew an engine and they've got 10 more, then probably it's not going to qualify.
The rules that govern this and sort of the general policies, are those in statute or is that at discretion of DSHS? Discretion.
discretion as far as extraordinary emergency.
Right. So first of all, I appreciate the update. This was discussed at Trauma Systems Committee. So I think this should be part of the ongoing sort of reminding people this fund is available. Really, the tone of, and I guess I'm the hospital representative, but the tone of that I guess it was RAC chairs, not Trauma Systems. RAC chairs was that, you know, at the end, if this fund is not used, then it's all dispersed and all goes to hospitals. I mean, in essence. So from my standpoint, I think we need to encourage using that fund for the intent for extraordinary emergencies. But if it's not routinely being used, or if it's not being, you know, if it's not being used, then I think I would advise DSHS to use discretion with respect to when there's EMS agencies that need something, and it's an emergency. I would encourage using those funds rather than waiting to the end of the year. And of course, the hospitals are happy to get that money. I'm not complaining about that, but it's, and I also understand that this fund is not just for EMS. It's for EMS, hospitals, RACs, for any emergency. But practically speaking, it brought up as an EMS issue. So I appreciate you mentioning it. I think this should be emphasized through EMS committee, that it should probably be like maybe if not a standing item, it should just be routine that people talk about, hey, this fund's available. You know, if you have an emergency, don't let your service deteriorate. Use this fund, get the word out. And then I personally would, you know, I think it's worth reassessing whether those criteria could be loosened with respect to particularly EMS.
We do have a balancing act, and we have to certainly justify if anybody questions us and looks back at the history of how we use the funds, whether they thought it was truly an extraordinary emergency. And I don't disagree with you. We for many years, we used them down to very small amounts. And so this has just been in the past couple of years. The balancing act is to have, if there is something that happens in July or August, to have that funding. So I agree with you that since we seem to be having this, we do need to kind of take a look at it again, but we also need to look at the intent of that legislation, and the intent was for truly an extraordinary emergency. So we'll look at it. Thank you.
And I wanted to clarify, so y'all don't hunt me down next week when you get 500 applications due to broken ambulances. That wasn't my intent. I was thinking in terms of a small nonprofit ambulance company in a frontier community that's the only ambulance they got, and they're going to leave it sit for 2 weeks waiting for money. That was the intent, so thank you.
Our other project grant, our other grant program is a local project grant, and for FY13 we had 111 applicants. 103 applicants were eligible. These applications are pending CSCU approval, so we had 83 applicants that were awarded funding for a total of $1.3 million. So we expect the contracts will start in October, and we would be emailing the awards in September. So that's 1.3 that would be going out to 83 different applicants. Okay. And that concludes my report, and I'll take questions.
Any questions from council? Okay. Thank you. We'll now hear from Commissioner Suarez.
Good morning. The Prevention and Preparedness Division and the Regional and Local Health Services Division, both of those director positions are vacant now. And Dr. Lakey thought it was a good juncture to tweak the organizations between the two. And so effective September 1, the Community Preparedness section will be moving over to Regional and Local Health Services out of the Prevention and Preparedness Division. The new name for my division will be Disease Control and Prevention. It's sort of a familiar name to me who's been there a long time. The move has been viewed very positively. Obviously, preparedness and response activities work closely with the local entities, and so all across the board, people are saying that this will be a very good move. Related to community preparedness, the hospital preparedness program grants the new funding started July 1st and then will go for a year to June 30th. We are still anticipating a 33% reduction in those funds the following year, and we'll work through that when that time comes. We've begun discussions about the request for proposal process, so stay tuned for that. A meeting is being scheduled in early September to discuss the HPP strategies for the next project period. Stakeholders will include the RACs, the hospitals, THA, the local and regional entities. And we're still looking for a date, and it's just going to be based on whenever we can figure out a hotel. An assessment of the FY13 HPP healthcare preparedness capabilities and functions are due to DSHS September 28th. All of the TSA assessments will be submitted to the CDC for analysis, and then once that analysis is complete, we'll report back to the RAC boards for review. And recently, in July, Bruce Clements, the Community Preparedness Section Director, attended a work group meeting in Washington, D.C. Regarding emergency care drug shortages. There were representatives from emergency medicine, public health, HHS, and FDA, and they were talking about the shortage and decision support tools, which would provide suggested options regarding expired drugs, some compounding options, and then the work group will develop pros and cons for each option. The work products out of that will be available later this fall. And then recently in the news, you might have heard about a small outbreak regarding West Nile virus. The SMOC is in gear, and we're coordinating the West Nile response, including the aerial and ground spraying and the public information messaging and also community outreach. And Bruce just gave me some statistics regarding where we are today. As you know, aerial spraying was commenced last night in Dallas County, and it covered 52,000 acres. 4 aircraft will be used tonight in North Dallas, north of I-30. And the ground spraying is continuing with 20 trucks. As of yesterday, we had 45 new cases across the state, bringing the total to 509. 285 were West Nile neuroinvasive disease, and 224 were West Nile fever, just with fever. And we've had 20 deaths due to the virus. We believe that this is not yet peaked. We are anticipating far more cases across the state. Any questions about any of that? Regarding the EMS trauma registry, we are scheduled to go live next month in September. The pace has really been fast and furious. Everyone is working very hard. The past 2 weeks, we conducted training webinars to provide instructions on how to use the new system. And we have had approximately 1,500 users who've attended at least one of the training sessions, so we feel we're doing a very good job in that. We're currently in the process of conducting user acceptance testing, and have scheduled a pilot for later this month to test the system prior to implementation. We want to thank all the EMS and hospitals who've been participating in our testing activities and really appreciate their support. And in response to suggestions that were made at the last GTAC meeting, we stepped up our webinars. We held 5 demonstrations of the registry system, 2 of them as webinars in June. And then we had 3 in-person demonstrations in Dallas, Houston, and here in Austin. And then we'll be holding another webinar August 22nd. And it's going to be open to all stakeholders. So far, 232 people have attended the webinars, and 106 people have attended the in-person demonstrations. In terms of the need for data dictionaries, we've created 3 dictionaries, one for the EMS legacy and the hospital legacy and the submersion reports. The drafts of the 3 dictionaries have been distributed to the Registry Solution Workgroup members and all registered users of the trauma registry. So they're out for review and comment. And then once we reach some consensus on the new elements and it's in compliance with the national standards, we're going to develop the dictionaries for the new system, and we'll send those out to all the stakeholders and users for, again, for review and comment. The new system, as you know, will require some software locally to be changed, and so we'll be working as a the timeline for transitioning to the new system for the local providers and vendors. We are planning to work with you. We know change is hard. We know it'll be a difficult process, but we intend to be supportive and help as much as possible to transition to the new system. The new system will accept any of the legacy solutions, so there won't be a problem immediately. We have also implemented a number of the validation conditions that we were seeking in the new system, and have modeled the validations based on the NMSIS and the NTB-DP, National Transportation Data Standards. Trauma. And we are continuing to work with stakeholders. We know there's a lot of interest in the validating the information going in, and as we identify the need, we'll work them into the new enhanced registry post-go live. We are also working on the collection of performance improvement data. We created all the performance improvement data fields in the new system. Concerns were raised that for the hospitals without their own registry software, whether they should use the trauma registry, the state trauma registry, for entering their performance data was questioned. And so we did a survey for all these users to see if they would want to enter the data in the first place, and whether their administrators and CEOs would be okay with this. We're currently compiling those responses, and we'll report the findings to you once all of that's been completed. And once again, we plan to go live in September, but we anticipate that we'll have a full year of enhancements and improvements. So we're going to collect user feedback and prioritize and work them into the next version. We were notified a week or so ago that TxDOT has supported our request for funding for FY13, and so we have a TxDOT funding in hand for those enhancements, and we anticipate we'll have the GR match at the DSHS. So again, once again, after go live from October to December, we'll be developing the customized reports and implementing the registration enrollment system. The registration for facilities, we want to automate that. We want to make it easy to get in and keep up with your updated information regarding your facility. And then finally, the injury program extended the deadline for reporting 2011 data and reached out to all the hospitals and EMS. And as a result, we had a 17% increase in the number of EMS records reported for the 2011 and an 11% increase in the number of hospital records reported. So again, I want to thank you for your patience and in working with us and supporting us throughout the process. And that's the end of my remarks, and if you have any questions, I'd be happy to answer them.
Go ahead. I was just going to say, does council have any questions?
I have a couple of questions. So I would just, for all three folks with respect to reports, I would emphasize moving forward the importance of the racks. The rack is really the core of the trauma system, stroke, cardiac, disaster preparedness. Preserving that skeleton is absolutely critical. It was, I know it was a DSHS idea, and I think it works very well. So moving forward, I think it's critical to support that infrastructure. Then just some detailed questions. If I recall correctly, was there HPP funding that went to support the trauma registry in the past? Is that continuing, or am I confused? What's the status of that? I thought there was I thought that was in part the way the state funded the registry. Am I wrong?
I'm going to ask Bruce Clemens to come up and answer that question.
No, sir. The trauma registry has not been funded up to this point with HPP funding, to my knowledge, unless there was something that was done prior to my arrival that I'm not aware of. But okay. Epic position? Okay. Many years ago. Okay, so there were some epi positions several years ago, but currently the budget does not support any of the trauma registry activities.
Okay, very good, thanks.
Okay. Thank you, Commissioner Suarez. Before we move to the next report, I forgot Kelly wanted me to remind everyone that the quarterly cheerleading camp that coincides with our GETAC meetings will be held today, and at 11:30 there will be raucous noise adjacent to us in some direction here, so we may have to break for a couple of minutes or just simply out-cheer them. The next item on the agenda is Eric Epley, Vice Chair of the Preparedness Coordinating Council.
Good morning.
Morning.
We met on August 15th from 9 to 11:30. We had an extended session. Sharon Knowles from the City of Houston gave a briefing on the STEER. That's the new registry for the State of Texas Emergency Assistance Registry. That will not roll out for the coastal areas this year. It will roll out next year, but for the rest of the state, it will roll out. It felt like it was a little too close to the actual hurricane season to roll it out this year. I would brief you up on a product called IPAWS, I-P-A-W-S. There's a lot of other names that are being used with it, but essentially it's a methodology the federal government is rolling out to states and local jurisdictions, which allows your cell phone to receive an emergency message. Sort of like on the TV when you used to watch it when the tornado warnings came out, except that it hits your phone based on geography. So if you're from Cleveland, but you're on the Riverwalk in San Antonio, when we put the message out, you'll get that message, but you won't get the one in Cleveland because you're not in Cleveland.
That's a good thing.
The EMTF work group, Victor Wells and the team with the Emergency Medical Task Force has just been doing phenomenal stuff. Of note for GETAC probably is the fact that DSHS will be stopping usage of what we call the direct agreement between ambulance providers and DSHS on December 31st of this year. So we're moving to a methodology where DSHS will contract with the 8 lead racks And those 8 lead racks will have sub-agreements in place with the providers. And that's how the reimbursement process will work as well. So right now for August, September, October, obviously in hurricane season, we're having a hybrid. So some agencies have the new process in place. Many EMS agencies still have the old process in place. And we'll have the final document for the new process finalized in mid-September, and that will go out. Additionally, Chief Kidd is leading an effort with the governor's support to combine all reimbursement processes for the disaster response. I don't know if you guys know today, if the city of, I'll pick on Dudley, if the city of Schertz sends an incident management team member out and they go to a hurricane on Galveston Island, and then he sends a TIFMIS deployment, the fire side of the deployments, and then they send a Texas Task Force 1 USAR member, and he also sends an ambulance. Those 4 state agencies have 4 separate processes to get paid to go to the various, so the same 4 humans from the same department went to the same incident, and yet the HR people have to file it 4 separate ways. That's a duplication of effort that no one wants. It's irritating to the jurisdictions. It's irritating to the state. We don't get paid fast enough. The state doesn't get paid fast enough, so they're combining. They've already had 2 high-level administrative meetings, and those 4 state agencies, specifically at TDEM's leadership, are being guided. I would expect that's going to be a rapid process. Maybe in the next 9 to 12 months, we'll have the new way of doing that in a consolidated fashion. EMTF will follow that effort once it's in place. We're calling it Next Gen. We've participated on the EMTF side in a bunch of exercises and also real-world events. The ambuses are now deploying regularly, and just since we've met, they've deployed 2 or 3 times. Oddly enough, to nursing homes that are getting whacked by either straight winds or straight line winds or storms like a F1 tornado or power outages, and they're using the buses' ability to lay people flat. So you put 20 people supine in an air-conditioned environment at 104 degrees. That's pretty helpful, and not having to move them somewhere. Then once the power's back on, move them back inside. So it's one of the best evacuations you could probably ever use it for. Additionally, we need to be aware of these mega buses. I don't know if you guys have seen them yet. They're moving up 35, they're on 20, they're on 30, they're on 45, and they are double-decker. It's a Coach USA double-decker. They hold 83 people. The one in Chicago piled into a pylon on an overpass. So that's Merry Christmas, 83 people. Okay, FYI. We'll be developing a what is TDMS and what is EMTF video, and also a map to hand out. Probably most of the RACs, most of the EMS directors know. What we're finding more and more is the chiefs know a lot about things, but the Indians that are up and actually doing real work at 2 in the morning don't know much about all this stuff. So we're pushing that down to make sure we have quick reference guides and things to be able to use the EMTF assets like ambuses and things. Mitch Morber, Dr. Morber continues to do great work with his disaster medical care with scarce resources, building guidelines and strategies. That group is meeting almost monthly. They have 4 to 6 meetings scheduled, and they're going to start focusing on the inclusion and exclusion criteria for pediatric ventilation and other things. And that group will meet in late September. I don't have a date. Bruce Clements, who you guys just met, has some contacts in the state of Missouri and in other locations, and so he brought together a team of like-minded professionals from those other states, from North Carolina, Rhode Island, Michigan, Missouri, and somewhere else that I can't remember, in a process called the Interstate Disaster Medical Collaborative. We met in Dallas. The NICTRAC guys, Rick Antonese and his team, hosted the whole event. It was wonderful. We got a 2-day session and talked about how our EMTF looks like their disaster system, and there are a lot of similarities. Lots of exciting things to come out of that group in the future. Texas ETN, we did a demonstration of the emergency tracking network. The TWRP guys did a great job in explaining how that's working, and it's going to be much more hospital focused now. It's really been focused on the 100,000 gen pops, and now we're looking at the other processes that may have been left behind. There's some modifications we want to make it a little more user-friendly for hospital transfers. And finally, we had a wonderful briefing from a gentleman named Locke Mullen from Fort Bend County Office of Emergency Management on social media and emergency management. And it's phenomenal. Actually, actually have never, every time I hear the lecture, if you guys get a chance to hear Locke talk about this, it's one of the better lectures you'll hear. 40% of the population in America is under 30. 96% of that population under 30 has some form of social media, Twitter, Facebook, whatever. So we are going to see video from the scene before you even see it. You'll have it on YouTube. You'll have it on other things. So it's emergency management. It's actually an operational tool to gather intelligence as opposed to just a PIO putting out a message. It's not that anymore. It's becoming an actual operational tool. Finally, Dr. Maggie McGraw will do a summary of EMP, electromagnetic pulse. It's one of the things that's probably worse than a pandemic. We've never really discussed it much. If you really, probably, how many people know what EMP is in the room? Raise your hands. Oh, never mind, you all know. We'll skip the briefing. Oh, you're in my meeting. Okay, good. That's it. Any questions?
One question. The change in the process, is that going to affect Air Medical also, or will that just be?
So it will. So the deployments will come through your lead rack, but the dollars, nothing's changing except that you're going to file through the lead rack. I mean, if that puts you at ease. It may not.
Okay, thank you. That's all I need.
Any other questions for Eric? Can I get you to give your Disaster Emergency Preparedness Committee report as well, or is that all wrapped up in one? You're listed on the agenda twice, so if you can just nod yes.
Oh, ECC.
Yeah.
Yeah, we'll get that next time. John Leidiger and I were supposed to connect, and there was a summary that I don't have.
Okay.
I'll have it next time.
All right, thank you.
They did some amazing things at PCC this time.
Okay. Very good. Right, we will continue then with GETAC committee summary reports. Air Medical, Shirley.
Good morning, everyone. The Air Medical Committee met yesterday. We had a few items on our agenda. First was a report by subcommittee that we put together to look at possible recommendations for changes or additions relative to stroke or STEMI care. And that subcommittee didn't feel like there were any changes necessary at this time as regarding to Air Medical. We also had a discussion regarding the responsibility of patient care when a flight crew was transporting a patient in a ground ambulance. That was also brought up in a couple of other committees. We have a group of people that are working together to draft some questions to send to DSHS that will address the specific concerns that we have so that maybe we can, everybody can get this straight in their mind and know where we are. We also had a discussion or a presentation of a gap analysis between the proposed Air Medical rules that the Air Medical Committee did over the last couple of years and the draft of the model state guidelines that were, I guess, published by NSMSO. There were items in the Air Medical rules that were also covered in those model state guidelines in that draft that we felt were covered more in depth and more completely. There were some things in the model state guidelines that were maybe a little more in depth than what we had in our proposed rules. And then there were some things in the model state guidelines that we didn't address at all. So it was interesting to see that gap analysis. I think there's a hope that that analysis or that draft will be completed in the next couple of months. Maybe we will have it at least partly completed before we have our National Air Medical Conference in October in Seattle, and I think there's a hope to have that completed maybe by then. So we'll just watch that and see what that ends up looking like, and then we'll go from there, do whatever's necessary. The other thing we had, the one thing, and the reason I ask Eric is because I know the MOAs for air medical for fixed wing and rotor wing are completed, and I was told that they were on the website, and I've looked a couple times, and I'm a little bit website challenged, but I can't find them on there anywhere, so somebody's going to have to show me where they are. But they're supposed to be on there. The last thing, under general public comment that we had, the Texas Association of Air Medical Services is hosting a golf tournament in conjunction with the Texas EMS State Conference. It will be on November the 9th at Onion Creek Country Club. The proceeds from that golf tournament will assist with travel for the families to the Hall of Honor ceremonies. I have some save the date flyers up here if you're interested. We'd love to have you come out. It'll be a shotgun start at 1 o'clock. Onion Creek Country Club is where they played last year. It's a beautiful place to play. We'll also have dinner that evening, so if you don't play golf and you want to just come out and have dinner, I think the dinner is like $40 if you want to come out and have. It's a barbecue buffet. They'll be also doing a silent auction, which they will take from the golf tournament over to the exhibit hall, so that everybody will have an opportunity to bid on the silent auction items. And if you'd like to donate something, we certainly would be happy to take your donations. So I'll leave some of these up here at the front table, or put them out at the back table after we're done. So if you're interested, please get signed up. And that's all I have.
Any council questions for Shirley? Are there any action or agenda items we need to put on the November agenda? No? Okay. Cardiac Care Committee, Dr. Smalling.
Good morning. The Cardiac Care Committee met yesterday afternoon. The first report was by Kenton Holloway from the DSHS on the results of a survey by DSHS on cardiac care activities and stroke activities of the 22 RACs in Texas. 20 responded, and the results are tabulated in this tome, which hopefully we'll get an electronic copy of and be able to share with those that are interested. Most of the responses suggested that 55% of the RACs had either cardiac care and stroke care or one or the other present. Only 7 RACs had a dedicated cardiac care committee. There was a fair amount of discussion about this regarding both the currentness of the data as well as the accuracy of the reporting. Apparently there were some large RACs that did not report their activities for a variety of reasons, apparently. Everybody agreed it was a good step, and Drs. Wozniak and Mixon agreed to look at the data more closely, to formulate additional questions and potential better mechanisms for collection of the data. And everybody agreed it was a good idea to repeat the survey probably on an annual basis. There was some additional discussion regarding the Cardiovascular Disease and Stroke Council of DSHS and the Cardiac Care and Stroke Committees of GETAC having sort of a apparent duality of purpose without much communication. And so several options were discussed regarding a closer working arrangement from the Cardiac Care Committee and the DSHS Council. And I'm going to approach Tom Tenner, who's the chair of that committee, regarding what we might do, including potential non-voting memberships of the committees with cross-representation from each at the meeting. We next had a series of reports on materials gathered for potential website distribution. to shore up basically information and for the RACs on STEMI care. Lonnie Den also reported on the Duke Mission Lifeline STEMI Accelerator Project. Houston and San Antonio were chosen as sites in Texas for the project, and hopefully this will generate a fair amount of models for distribution to the other RACs. Catherine Bissell reported on the importance of providing STEMI case reports to EMS providers from the hospitals or the STEMI receiving centers. She showed a number of sample reports, and she and Dr. Peirce collaborated on a how-to document that we hope to post on the Cardiac Care Committee website. Todd Haugen and myself also reported on STEMI literature repository, both from the EMS perspective as well as for the cardiac care system perspective, which we also hope to provide on the website. And then Lonnie Den, Catherine Bissell, and Christine Uhas reported on STEMI system models for various geographic regions and population densities, and including best practices and how to organize such a system. And once again, we hope to have that on the website. We plan to have success stories at the subsequent committee meetings through the year with representation from various geographic regions. One of our committee members reported, for instance, on what's being done in Abilene, which is a huge geographic area. Christine Uhas touched on Corpus. So we need approval from this committee to pursue a mechanism for giving web access for this information, whether on the GETAC Cardiac Care Committee website or potentially providing links to a third-party website from the GETAC Cardiac Care Committee, similar to what's being done for the video streaming. So, Mr. Chairman, I would request a motion for approval of that.
As far as you're just looking for a place to put all the information about STEMI and cardiac items, and you're asking whether it can be put on the Department of State Health Services GETAC website or a third-party location with a link, correct? I'm looking at Director Guerrero here.
Some of it we're doing a little research on. There are some copyright laws that we have to be sure that we don't infringe on, and Kelly Harrell is looking into that. We would love to be able to put some of these links up or documents similar to what we've done for medical directors as a repository for information for EMS providers, RACs, whomever. So some of it we don't quite have the answer to yet. Links work better for us simply because if the information is updated or changed, then we don't have to police that.
So, Doctor, I think what you're asking for is just the council to give your committee direction to pursue that. Is that correct? I think under our newly modified strategic plan, we don't even need the motion. Unless there's any council objection, you're free to go ahead and pursue that.
Thank you so much.
Thank you.
Under public information, the CEDTRAC is going to have a STEMI meeting at Rice on September 22nd, and it's targeted for EMS physicians and all others involved with STEMI care, and there'll be a number of speakers and workshops. So there's some brochures out on the table. That concludes my report.
Any questions for Dr. Smalling? Thank you. Education Committee, Jody.
Good morning, everyone. Education Committee has met twice, July 22nd as well as Thursday. We have been working on transition courses, as everyone knows that if you want to keep your national registry, depending upon when you went to school, when you recertified, because of change in curriculum, there are some transition courses, or transition data rather, that will comprise a transition course. DSHS asked us back in October 11 as a group to try to identify numbers of hours needed in transition, and pretty much the committee since that time has been looking, and we had asked for a work group which consisted of Ryan Wolford, who's the director at Methodist Dallas, and Brian Erickson, who is at Tarrant County College over in Hurst, to work on an outline. It took them several months, but they submitted a draft to us, and it was basically the draft outline of two things. One's a paramedic refresher, and the second one's a transition course. In looking at this, the committee and the work group together found that if we take some of the card courses and put those together, it will actually take a lot of the transition material and add it to it, to give you a variety of ways to actually do this, partly through card courses and partly through the transition course. We did review the draft, had a lot of discussion. Could this be done in an ongoing CE program? Will we need to get an additional number? The language in our EMT refresher by CE equivalency and in our EMT transition by CE equivalency are things that we're still looking at. The transition content, though, will be tied to an individual CE course or initial number or approval number. So after looking at this document, we will be placing this, asking DSHS to place this document on their website for the next 30 days for public comment. It's about 8 or 9 pages, and they actually did a great job with it, but the paramedic one is actually due last. The other ones are due first, but the committee felt like this would be the most difficult one to do, so we started this one first. Looking at all of the essentials, making sure that we had the flexible core content, trauma, OB, operational task, EMS systems, prep essentials, anatomy and phys, lifespan development, airway management, AMP, patient assessment, medical essentials, neurology, cardiovascular, toxicology, non-trauma, shock, resus, soft tissue, abdominal and genital urinary, orthopedics, special patient populations, EMS operations, and making sure that there were some skill considerations that were in the gap analysis. And one of the challenges for the committee was to take the 2009 gap analysis and kind of put it together with transition, so that we would have a course or documents or thoughts that would actually be workable, including BiPAP, CPAP, PEEP, end-tidal CO2, nasogastric tube, OG tube, King airway, chest tube monitoring, indwelling catheter, implanted central line ports, Morgan's lens, and administering physician-approved meds, and the medical legal discussion that goes with it. So we're going to put this document out for public comment for the next 30 days with a link on the DSHS website. Member Kelly Weller has asked that EMS certificates may complete the National Registry transition process by attending a DSHS-approved CE or initial education program that meets the minimum guidelines and content of NASIMSO transition template. Course completion documents must bear the course or program number. And Mr. Chair, we're asking that this be put on the November agenda for action by council after at least a 30-day open public comment period, as well as our next scheduled meeting. So we did vote to move that forward. We will have that pretty much took up all three objects on our agenda. We will be working and have been notified by Jeff Fritz, who's program director at Temple College, of working with the military as they come back, trying to transition back. A lot of their training, some of it translates, some of it doesn't. and he's working on a program, on an education program to help those veterans coming back who have EMS backgrounds, to help them assimilate back into civilian life, and we would like to take that opportunity to assist him in developing what's called a 91 Whiskey course, which is pretty much the paramedic course, and the 91 Bravo, which is the basic course to help them when they come back. We will have a full agenda. Our next meeting, our next work session is scheduled October 5th here in Austin at the Learning Resource Center right around the corner. We'll be looking at still the transition course, the template, setting standards for equivalency programs and transfer programs, discussing requirement for medical directors of CE programs, taking a look at online education programs, and looking at DSHS negotiation of contiguous state regulatory agreements, which has come up again. We'll also be looking at student representatives and their practice during clinicals, where that student is represented and who's responsible for them during their clinicals. Is it the education agency, or is it the ambulance provider who's allowing them to have that experience? So we'll have a pretty full agenda, and that's it.
Any questions for Jody? Thank you. EMS Committee, Dudley Waite.
Good morning, everybody. EMS Committee met Wednesday at 2:30 in the afternoon. We had a work session scheduled for Tuesday that at the last minute had to be postponed. We received a report and an update from EMSC, and I'm sure you'll hear more in depth on that from the Pediatric Committee. We also got an update from the work group between the Air Committee and the Air Medical Committee and the ground providers, looking at issues. I'm sure they mentioned a little bit of this, looking at issues between two different agencies when they're on the ground together, whether that's fixed wing or rotor wing, and some of the things that have come up, and they're working on some questions, and the EMS Committee will be looking at those in November. Let's see, what else? We talked a little bit about what we were going to meet on Tuesday about. Our meeting on Tuesday was to look at and start working on some suggestions for rule changes to help address some of the growing numbers of EMS ground providers in metropolitan areas. And that work session got rescheduled during our committee meeting, so we're going to be meeting on October 12th in Dallas. Dallas Fire Rescue is going to help us secure a location up there. And we'll be getting that notice out just as soon as we can, but that'll be on October 12th. And we'll be diving into some of those suggestions that have been brought to DSHS and been brought up at the different times we've discussed this to the EMS Committee. And trying to formulate maybe some rules and some suggested rules to address some of those issues from the ground provider perspective. We had an update on the pharmaceutical shortage issues and sharing of some best practices and what different areas of the state are doing to address that. We also talked a little bit, most of the governmental ground providers in the state got a letter from HHSC with the potential of some additional Medicaid funding. And it's elicited a lot of questions among the governmental ground providers. Is it worth it? Is there risk to it? Basically, HHSC says that you can complete a cost report annually and submit that, and if your costs are greater than what Medicaid reimbursed you, then they will reimburse the governmental ground provider the difference of that. The slight risk to it is that if somehow or another, which everybody knows what Medicaid pays ambulance providers, so I'm hard pressed to see where this could actually happen, but maybe to a small governmental provider that utilized a large number of volunteer employees, is if what Medicaid paid you was actually greater than what your costs were, then Medicaid's going to want that additional money back. So it's a small risk. The issue is it's the amount of work it's going to take to fulfill their cost reporting requirements. So there's a number of ground providers, governmental ground providers, that are looking into that and maybe trying to take advantage of that. We also got an update during that meeting, and this is the reason the Medicaid issues are so important is because On January 1st, HHSC stopped paying the crossovers for dual eligible. If somebody has Medicare and Medicaid, Medicaid paid the copay after Medicare paid the 80% of their allowable. January 1st, Medicaid stopped paying that if what Medicare paid was greater than what Medicaid would have paid if they were the sole provider. This has had a drastic effect on EMS or ground ambulance providers all over the state of Texas. Some of them seeing 60 and 70% reductions in their Medicaid dollars. And so we got a little bit of good news at the EMS committee meeting on Wednesday when it was announced that HHSC has agreed that starting September 1st in the new state fiscal year, that they're going to reinstate those crossover payments on emergency, Medicaid definition of emergency calls and hospital-to-hospital transfers. It's not going to address the non-emergency patient movements that are going on out there, and there's still work being done with HHSC to maybe address some of those as well. So that was a little bit of good news. And then lastly, we reminded everybody in the room to go back to their home jurisdictions and to share with all of their ground providers and air providers the importance of paying attention to the letters they get from CMS, because with the Affordable Health Care Act, one of the things they're doing is they're requiring all ground providers to revalidate their Medicare registration information. And there's been a few providers around the state that for one reason or another, because maybe they're volunteer or they have a billing company and they've changed their address, but the right address didn't get updated with CMS, they've missed those letters and they've lost their Medicare provider number. And once you lose that, it's very difficult to get it back. And so it's had some bad effects on some of these providers. So Kelly Harrell worked with me and we were able to get an article out in the magazine about it. And we're continuing to ask people to remind folks, if you see that letter come from CMS, not to ignore it, not to just put it aside and say, hey, we'll deal with that later, I don't really understand what it says, but send it to your billing company or contact an agency around you that is savvy in those things and get some help getting that revalidated so that you don't lose that funding source. And our next meeting is October 12th in Dallas, and we'll be back here in November.
Any questions for Dudley? Any action items to go on the November agenda?
Not from this meeting, no, sir.
Okay, thank you. Injury prevention, Shelley Stevens Stidham. Oh,
That committee didn't meet.
thank you. Medical directors, Dr. Greenberg.
Yes. We met on Wednesday. We had a quorum present. We followed our agenda and got multiple reports, many overlapping with some of the previous committees, so I won't go into those. We had a limited amount of public testimony. Most of our discussion was about Texas Medical Board Rule 197 and the verbiage which is going forward. In a surprise to all of us, I would say that the medical board, the medical directors, and DSHS, we're all pretty much on the same bus on this one. We're all going the same direction, and I think once we get some of the language to where it should be, I think we're all going to be very happy with this, and it should provide an improvement in everybody's life. It sounds like it's opened a door between DSHS and Texas Medical Board as well, so that's probably the best thing to come out of it. As far as some action items we added Drs. Hinchy, Kovar, and Purse to the mentor list on our webpage. We've added the FEMA handbook on medical direction to the webpage. And we do have next meeting, we're going to have a couple of position statements we are going to look at. One is a position statement on EMS transport to non-traditional or alternative sites. Basically, the issue of freestanding emergency departments and urgent cares. We'll bring a draft to this council, but I don't expect it to be finalized. I think this is going to take a while. We're also going to, and Dr. Rich Bradley is going to take the first swipe at that one. Dr. Jeff Jarvis has already worked on a position statement on medical director's responsibility for clinical care provided by EMS students on clinical rotations, very similar to what Jody was talking about. I think we probably can knock that one out next meeting and would ask that be put on the council's agenda for November. So one, I'd like to bring a draft of the position statement on EMS transport for November. to the council for review, and I expect it to go back to medical director committee and possibly EMS committee, and then action on a medical director's responsibility for clinical care provided by EMS students. We also have one request that we could meet on, the medical directors committee could meet on Saturday, because on Sunday there's a conference that most of the medical directors will be attending, since it's during the Texas EMS. And that concludes my report unless there's any questions.
Any questions from council? Thank you. Pediatric, Dr. Macias.
The Pediatric Committee met yesterday. After a committee liaison reports, the EMS for Children State Partnership update was given. There were two critical elements that represent work that are being done in conjunction with the PD subcommittee. One of them is the online and offline medical direction surveys. Results were presented with excellent response from providers and good response from the directors. Interesting to note that pediatric calls make up about 21% of all calls for online medical control, and some of the perceived barriers were described, but what was most important from that was that there was certainly support from both directors and providers for regionalized, standardized, evidence-based protocols. So a conceptual model that really supports moving forward with those kinds of quality improvement strategies. As partner to that, there was an update and review on pre-hospital evidence-based summaries. I'll remind you, this was a sub-grant that was provided by Emergency Medical Services for Children's federal office to support this work done at the Evidence-Based Outcome Center through Baylor. And this included evidence summaries for cervical spine injuries, management of shock, including post-resuscitation management, and non-transport of pediatric patients. There was a lot within those summaries, so I'm not going to go into the details of that, but we can certainly post that. I think what's most important about this conceptual model is that evidence-based summaries provide the knowledge translation piece that's done by experts and really help us to synthesize that in something that's useful for agencies to develop through their own values and preferences. So protocols can then be developed in a much easier fashion, recognizing that the bulk of this work has already been done. Next steps, of course, are to disseminate that information and make it readily available to users. We tabled the Child Fatality Review Team update. We had a discussion on pediatric imaging with finalization of our position paper that was developed with the following recommendations, slightly different than what we had initially proposed. One, that all CT scans on children should be performed using pediatric dose reduction protocols. Two, that avoidance of the use of protocols which automatically result in the performance of multiple CT studies in pediatric trauma patients. Three, imaging modalities that do not use ionizing radiation, such as ultrasound, should be used when feasible. Four, that understanding and linking guidelines of care that utilize evidence-based practice strategies will help minimize the use of unnecessary testing. Five, that the avoidance of further CT imaging once the decision to transfer to definitive care is made, unless the accepting institution specifically requests a scan prior to transfer. And six, accepting institutions should avoid repeating scans, consider access to a cloud-based digital image translator. The position paper itself is fairly lengthy, builds a case for this very unique problem amongst children. I want to stress that we really do consider this to have full responsibility within the pediatric subcommittee because this is a problem of radiation to a growing child that results in malignancy and an increased risk of malignancy and malignancy-related death. So it is that nature of a pediatric issue that makes us really want to push this and really ask for endorsement of the committee. So, of the council. So specifically, we have the statement. This statement was created in 2012 by the Pediatric Subcommittee of the Governor's EMS and Trauma Advisory Committee and reflects the opinion of GETAC. This is important for us because children's hospitals go into payment reform for APR DRGs, and much of the value model is shifted in 2013. We will be seeing a lot more value-based care and quality standards, and we really like to see the endorsement of the entire council. My understanding is there's not an exact mechanism for how this might be adopted, so if there is discussion on what the governance and what the statements of endorsement should look like, please take this into consideration. For future for action items, we'd like endorsement of the position paper in your November meeting. And just for future agenda items, the one important piece of this, both the pediatric imaging statement coupled with evidence summaries, dissemination strategies represent the next year of work that our subcommittee will be doing on disseminating best practice and support models for institutions, agencies, any organization that's wanting to improve quality of care. So providing real means for that is what we'll embark on for the next year. But this has given us the platform for that. Any questions?
I just have a concern. The position statement y'all did for imaging is very good. Like you said, it's very lengthy. It was clearly well-researched, a lot of work. It just comes across as very much a medical practice guideline. And I'm a little concerned as to whether or not that should be coming from us or not. So I'm looking at the state and think we should just discuss it. Don't get me wrong, it's mom and apple pie. There's nothing wrong with the statement at all.
Yeah.
It's just whether or not it's appropriate for us to do that or if there's another venue that would be more appropriate.
I just leaned over to Jane and said, we've got to have a discussion about this to make sure it's a challenge. Some things are quite within your purview and some things step over. The other interesting issue is the more things y'all are doing, and you're doing such wonderful work, everybody in this room across the state, you are entering into the purview of so many other pieces of my division, from the drug shortage thing, because I license manufacturers and distributors of prescription drugs in the state of Texas. And so, you know, and then we have the Texas Radiation Advisory Board that is under my purview. So we need to be looking at those kind of things. Also, we license MRTs. So so much of this work, it's wonderful stuff. We just got to figure out, make sure we stay, you guys stay in your lane, we stay in our lane, but not to discourage. And maybe this, I don't know the answer right now, but I did lean over to Jane and said, we've got to make sure we know what our lane is. I want you guys to do it. I want you guys to put these things out, from the medical director position papers to these kind of things. We just need to make sure that what are they called, and who actually posts it? Is it a link from us, or is it actually posted on our website? Just lots of questions we have. So don't stop doing this good work. We just got to figure out exactly how to get it presented out there.
If I could make two comments about that. One is that we definitely value the opportunities for collaboration, and we have reached out to Environmental and Consumer Safety section, and they had representation there as well. And I think coexistent with their rules changes upcoming, our strategies for quality improvement will link back to that. And so we're very, very respectful of that. The second is that we're not the first state to embark on this. Pennsylvania has had a very solid approach to minimizing ionizing radiation. Part of our strategies for dissemination will partner with the American Academy of Pediatrics and some of the professional societies for a September 2013 rollout.
Yeah, no, I think this is great work. I agree. It's just I'm not sure it's within our purview, and I don't want to step on toes either. So I throw that out more as a question. And how can we make the best use of this work? Because it really, I mean, there's nothing in there that's controversial, I don't think. I don't know if the radiologist would get upset about anything on there or anybody else, but again, it comes across to me as a physician practice guideline, which is not within what we should be doing, I don't think.
Well, and I think a large part of that is really related to infrastructures of care, so protocols that exist prior to a physician, protocols that exist for institutions, protocols that relate to transfer, all of that isn't medical practice driven, it's really healthcare infrastructures.
But it's clearly practice, right? I mean, it's so but I think it's within our purview. I'll just say, I just think, to me, I'm going to just give my suggestion for how I think it clearly comes in our, we don't dictate, but we basically list a bunch of rules that you have to follow if you're going to be designated a trauma center in Texas, down to very detailed things of what FTE, fraction of an FTE you have to have. We recommend, and we do more than recommend. We say you have to meet this criteria. You have to do these things if you're going to be designated a trauma center. So, but that doesn't come from GTAC endorsing that. In other words, the GTAC committee, it's not required for GTAC committee to say, we think that's a good thing, because the problem with that would be that when that evidence changes next year or next month or whenever, you're gonna have to come back to this committee for that. To me, within the purview of the structure of GTAC, what I would recommend from the pediatric committee is to basically, for the key things, look and see whether those fit within the rules of the rules for trauma center designation level 1 through level 4 trauma facilities, and basically move that into language that could be adopted in those rules. That's really the way the structure works. And that actually puts it, now it's going to be, I'm going to say what I think would happen in that situation. It's not going to be that, it's very unlikely to be that exact same statement. But what probably is likely to be is to a criteria, or certainly a recommendation. I mean, this could easily be a desired, but it could be even essential. It's probably going to be that there needs to be a protocol or adoption of guidelines for reducing unnecessary radiation in children, that gets in that, and then you can reference, your statement or professional statements. I think that's the way to proceed.
So I think, and I appreciate that, I think that would be helpful for about half the problem, and that's unnecessary radiation from trauma, but that doesn't address the other infrastructure issues that are related to transfer of children in hospitals across the state that are medically driven but emergent care driven.
Correct.
So that I think that could be one of the dissemination strategies, but I think we have an opportunity to make a statement about healthcare settings that's unique to this particular problem and can really isolate and focus on where the crux of the problem is existing in the state, and that's in emergent care settings, whether it's trauma-related or non-trauma-related. So something to think about. I don't think the solution is going to come up in this discussion, but I also think that as we move forward with strategies for dissemination, this discussion will come up several times. And so it would be helpful for us to also understand not just is this something that we can adopt, but what are the confines of the scopes in the future.
I just want to say a quick thanks for looking at that, because being on the other side of that, being a transporter of those children, whether it's trauma or whether it's a medical issue, it's not infrequent for us to pick up a child that has had x-rays in a sending facility, and we take the disc with us, take them to a receiving facility, and before we even get them in the door, they're sending them off to CT or to x-ray when we have the things that they need right there, and they won't even look at them.
Yeah,
So thank you for looking at that.
Thank you.
Is there some other venue you could also publish this in? Do you know, is there a statewide Academy of Pediatrics newsletter or anything else?
So in our November session, our intent is to describe dissemination strategies, including professional societies. And so, yes, there will be other venues, okay. But the crux of, as I mentioned earlier, is really within our emergent care infrastructures. So.
Any other questions? Thank you, Doctor. Stroke Committee, Dr. Rutledge.
Good almost afternoon. We met 9 o'clock yesterday, and the first thing that happened at the Stroke Committee was that Daniel Pyle and Catherine Bissell of Houston presented an outstanding presentation on how they're collecting stroke data at their RAC level there and their survey. And that was used as an example of a potential way that RACs could collect stroke data. Following that, the American Heart Association did a overview of their Caruth initiative in Dallas. This is where they're doing data collection on STEMIs like time to door, time to groin, time on scene, things like this, that they also believe could be applied to stroke data and to look at stroke in the context of EMS. Because of that, we formed a subcommittee, Ron Eichler, that is going to look at developing a RAC stroke data collection or surveys that we might be able to use as a best practice model to distribute to the other RACs to just try and improve stroke care and the EMS care. Also, you heard earlier that CSC Comprehensive Stroke Center certification is just about to start. This is the equivalent of a level 1 trauma center and will affect us in transport plans and bypasses. As you heard, the website will be up September 1st and applications will be up October 1st, and we're going to start January 2013. Yes?
We'll start accepting applications in October.
But the actual transport plans and stuff, 2013-ish, January. So that's very exciting because it's going to affect the stroke care and how well people are moved around. Next, Kitten Holloway presented it's actually a long name, the Summary of Survey Responses for Assessment of RAC Implementation of GETAC Recommendations, which was done in 2011, and you also heard in the cardiac report. Regards to stroke, 16 RACs responded, and only one of them did not have a regional stroke plan. Unfortunately, because this is 2011, that's sort of data that's a little bit, I'm sure everyone has stroke plans and stuff down. And so another thing that this subcommittee that we formed will probably look at is how we might use survey monkeys or stuff to get more information on that and then distribute that to the different RACs so that they have best practices and something they can do. The committee also voted that the RAC survey to make that public information so that everyone can have access to that, and we'll go about trying to do that. We had no public comments. There were 2 announcements. The Texas Brain and Spine Institute is doing a neuroscience symposium in College Station September 2012. And the Seton Hospital Network is doing a stroke symposium redefining what is possible, October in Austin. Are there questions? No action items.
Okay. Thank you, Dr. Rutledge.
Welcome.
Trauma Systems, Jory Klein.
Good morning, Mr. Chair, members. The Trauma Systems Committee met on Wednesday. Our focus was the continual review of the rules. I think we're pretty concrete on what the rules are going to be. There's still a few questions. There was a large part of the time spent on the trauma registry. To say that there are disparities between the stakeholders and the development of the registry is an understatement. But I think we have a workable solution. And so the solution is that with TAMI support and the stakeholder support, we're going to form a work group off the Trauma Systems Committee. In addition to that, we're asking that they have the registry work group solution meetings in conjunction with GETAC, the GETAC meetings, so that more people can participate. The work group that we would like to establish would include members from all the other committees. For example, we would ask somebody from the EMS committee, the Air Medical Committee, the Medical Directors Committee, to all participate so that when at the end product, everybody is aware what's in that registry and what its capabilities are. It is the Texas registry. It is our registry. So to point the finger and say, you know, they're not doing something is sort of foolish because it is our registry. It's our data. So if you have recommendations for us, we would certainly entertain that. In addition to that, we would like to begin to develop a trauma system plan for the state of Texas through the Trauma Systems Committee and the different stakeholders. So those are the goals or our working items for the next quarter until we meet again in November. Any questions that I can answer for you? I stunned you? If not, I would just like to also add that we did have a rack presentation. Actually, it was, they created booths, brought their booths to display what they do in their racks, and we also had posters. We had 22 posters, and I think there were 14 racks that participated. I think most people who walked through felt like that was a very worthwhile endeavor, and that we will try to establish something like that for every May. So here's notice, so nobody can tell me I'm not giving you timely notice. Here's notice. We're going to do this again in May 2013, and the ideal is if you have had a poster that you've presented between now and May, we're asking you to bring that so that other people can see the work that's being done by the providers in Texas. Any questions?
Jory, I'd just like to say, as someone who went through and looked at each and every poster, there was a lot of hard work, and a lot of effort, and a lot of research, and the RACs did a great job of not just having sessions, but having information sessions that had depth, and it was really nice to just see that, and kudos to everybody.
There is one individual I would like to recognize that participated, and that's Christine Reed. And it's really her RAC, and they did a drowning video. Most of you are familiar with Shattered Dreams, and they took that into the water. It was very impressive, and I think that's something that we should be very proud of, that our stakeholders are investing time. That's what the RACs and the concept of building a system was all about. So again, I congratulate their RACs. Thank you.
Thank you, Jory. I apologize, I had to step out briefly. TTAF, Dinah Welsh.
Good morning. Guess it is still morning. Welcome to Friday of GETAC week. Thank y'all for allowing the time for TTAF to update you all on what our activities have been recently as we continue to work to further develop the EMS trauma and acute care systems in Texas. One of the things that we're really excited about that has happened since we met in May is one of TTAF's goals has been to become a continuing education provider for nurses, EMS, and ultimately doctors as well. And we are well on our way to be a nursing and EMS CE provider, and actually have a number of courses lined up for the fall that will help us achieve that goal. September 17th, we will have our very first EMS Lunch and Learn. And you would think that Dr. Rock had gotten with Kelly Harrell and knew what the cover of the Texas EMS magazine was going to be, because on September 17th, his Lunch and Learn will be on drug shortages. So he will, we will have a webinar. We will be getting that information out here in the next week about registration and participation in that. But we're really excited about launching that. Our desire is that we will be doing those monthly for EMS providers, and there will be continuing education credits provided for that as well. And that is something that I know several have had that idea for a while, and we're thrilled to finally launch it, including Ryan Matthews. I think it was about a year ago. It was like, hey, can't we do this? Get the education out to the people out in every corner of the state. So we feel like this is a great way to do that. We are readying for the legislative session. It seems like I was just talking about this, and I don't know where the time goes, but there seems to be a little bit of deja vu all over again, in that we are back in the position of defending the monies that we have, as Kathy pointed out earlier with the LAR and the reductions that they have had to propose with the 10% cut. We've got our work ahead of us once again, and but I think there's also a glimmer of light. We have legislators and some key legislators, including the Speaker of the House, that have gone on record talking about how important it is for the legislature to actually have dollars that are for dedicated accounts go to those dedicated purposes. and he highlighted the trauma funds. And I think for all of us, that's a no-brainer, but the challenge is there's a lot of spaghetti noodles that are tangled with that. And the $400 million that sits in account 5111 is, while it's not used, it's used as a credit for other things in our state budget. And so it's very complicated, but again, I'm thrilled that the Speaker of the House, the Chairman of the House Appropriations Committee, and several other Appropriations Committee members have acknowledged that this is a problem. And again, the Speaker of the House did acknowledge specifically the trauma fund and the plight that we're facing. So we're thrilled to have that momentum. We are, as we get ready for the legislative session, we're looking at doing a public survey, probably after the November elections, because everybody's going to be getting lots and lots of calls on who to vote for, but probably in November, December, to get public perceptions on EMS and trauma, and that data will be used to go to the legislature with. And we'll be working with, my hope is that we'll work with several of the groups, several of the committees to get ideas for questions. There will probably be, I'm thinking in the realm of 10 to 12 questions. We will be working with an agency that will actually conduct the polling, is what it essentially is, and they will make phone calls and go through a series of questions and try to gauge people's perceptions and understandings of EMS trauma systems in Texas and what they believe is out there and what the reality is. So again, my desire is to work with a number of the different groups that I know are represented here to get some input on those questions before we roll that out. We are planning another EMS and Trauma Day at the Capitol. It seems like a long way away, but it will be here right around the corner. It will be February 26th, which is the Tuesday of GETAC week. And I think in 2011, it was a very successful day, but we've already got some additional things on tap, and we will be working with legislators and the governor, speaker, and lieutenant governor to get some key meetings, as well as a governor's proclamation and some other things like that. So we'll start spinning our wheels to work towards that goal right away. I had mentioned our goal of becoming a continuing education provider. I'll just mention there's a couple courses that are coming up, including the EMS Lunch and Learn. We have a data management course that will be held September 14th in Conroe, and it's a course that's been created by the Texas registrars for Texas registrars, and we believe it's the first one of its kind, and so we're excited about that. There's some information out on the table about that course, as well as the Stroke Symposium. This is a course that we've held before in Austin. We are now starting to take that out. It will be held in Lubbock, October 12th, January 18th in the Woodlands, and then we're looking for a late spring date in the Valley. And the last thing that I'll mention is Jory had talked about the celebration and the posters that took place on the other day. We are going to continue to celebrate the 20 years of the Texas trauma system, and in November are lining up a number of different things, including some media, trying to get some editorials out there, some press about the trauma system and what we all do, what we all work towards. We will be recognizing some of our trauma champions, working with the governor's office again with the governor's proclamation. And then lastly, we will be having a fundraiser at Esther's Follies. It'll be a really fun event on November 11th, and that's the Sunday of GETAC week. And we will make sure that you all have information about that. Would love to have y'all participate in that fun evening. But again, that's hopefully a culmination of celebrating what you all do every day, and that's saving lives. Happy to answer any questions.
Any questions for Dinah? No? I just want to say thank you again for broadcasting for us and all the other things you do, and it amazes me. I remember several years ago being in the meetings that were the charter meetings for creating what's TTAF now, and seeing how it's gone way beyond what we were thinking at that time. So it's a marvelous thing to see. Thank you.
Well, thank you. It's exciting to try and realize the potential of so many great leaders. And I want to thank Jason and Russell for keeping the Russians at bay and destroying the Ustream account this time. So we appreciate their service. Thank you so much.
Thank you. All right, we're on the back side of the agenda, and we're going to discuss the strategic plan document. And before we get into that, wanted to I have a few comments that I think are on behalf of the whole council, and they're welcome to chime in. We've been working hard on developing a strategic plan for this council, and I think the key word there is strategic. Because we try as a council to maintain an overview of the entire process or operation. And so we hear things from stakeholders. We want to hear things from stakeholders. And with that information, with information from committees, and through a lot of, it was stressful, but I guess it's really become eustrous. And we've come up with some solutions that we think are going to improve our process. We have so many things. There was even discussion today, even with the pediatric. It's a process issue. What do we come up with? How does it get disseminated? Who reviews it? Who approves it? What all the different areas that it impacts? So, needless to say, where I'm going with this is the council has decided to make some changes that we think will improve the process. They're not an attempt to cap or contain or control stakeholder input, but they're meant to capture and coordinate that a little bit better than what we've doing, because I think if we keep doing things the same way every single day, that leads to that definition of insanity. So we have had comments from stakeholders that as this process has grown, that perhaps they don't have as much stakeholder input as they did. And so we as a council have voted and approved a strategic plan that we think will go lead toward better stakeholder input, lead toward better coordination of topics, and make sure they get handled timely and accurately and completely to the best of our ability. So with that, what I'd like to do is move into the first item, which is every year the GETAC chair goes to meet with Director Guerrero and her staff, and we get to select the committee members. And those committee members or fill in the committees that we have, and it's sometimes I don't have enough of a brain, I guess, to make wise decisions and committee appointments, and sometimes we have lengthy discussions with the committee chairs. So what the council has asked is that I appoint an executive committee that consists of 2 other council members beside myself that will help select those committee members every October. So at this time, I'm looking for any council members that would like to volunteer to assist with that process in October. And the only caveat is that I would like, if possible, for there to be 1 physician participating in that.
Well, Ronnie's gone.
He ran out the door.
So sounds like
I think we can do this. We can do this just like we do with the committee chairs through conference call. You don't necessarily have to actually be there in the room with us, although it is very handy to see the map of Texas, because we look at that map and try to make sure that we cover the state correctly. So then can I go with Judge DeLoach and Dr. Greenberg? Is that what I'm hearing? Okay, thank you. That was timely of Dr. Stewart, but of course, you never know what you're going to get appointed to when you're not in the room, so. While we're talking about committees, if you want to serve on a committee, that process will be online starting September the 1st and go until September the 30th. If you are currently on a committee, or you are currently the chair of that committee, and your time is up and you wish to be reappointed, you must fill out the paperwork. I'm going to say that again. If you are currently on the committee and/or its chair, and you want us to consider you to be reappointed, then you must complete the application. So please do so. It's very important. I know we're all busy, but it doesn't take that long, especially if you have what you put in last time. It shouldn't take that much time. Did I capture everything that we need to on that? Okay. The next thing I'd like to discuss is Goal C of our strategic plan. Can we put that up on the projector? Okay. I'm going to read off the paper, so if someone sees something different than what's on the screen, please let me know. One of our items from our strategic plan was Goal C, and it involves the committees. We've decided this time to keep the 10 committees, always open to further review, and we'll review that biannually. In other words, every 2 years, the GETAC will conduct its strategic planning for the next 2 years, and we will decide then whether we want to keep 10 committees or go to 15 or drop to 5 or whatever, but we'll look at that. At least we know we're going to look at it every 2 years. The structure of the committees: the chair is going to appoint a council member to each committee. The appointment can serve as chair of that committee, as Dr. Greenberg does for medical directors. They can be just a member or any other status as appropriate. And the role of the appointment will be defined depending upon the status of the appointment as to how the council member is supposed to interface. Suggested topics for the committees will be submitted to the GETAC chair, and then those charges will be considered and distributed to the appropriate committees for review. An example is someone comes to Dudley's EMS committee during public comment, says, "I think that all ambulances should be orange." Okay. It pleases me to no end to know that people in the back of the room are actually listening to what I'm saying up here. So anyway, that all ambulances will be orange. Well, instead of the EMS committee taking that up and putting it on their next agenda, when they come to the GETAC meeting, they will bring it to the council and said, "We had someone during public comment say they want orange ambulances. What do you want us to do with that?" The council may say, "We're not going to discuss that topic. You don't need to put it on your agenda anymore." Or they may say, "Yeah, we'll go ahead and discuss it," which will probably be 99% of the time, but we think medical directors have a say-so in it, and trauma, and so then the topic will be routed to the right committees, because I can tell you, meeting after meeting, we've heard people stand up here and say, "Oh, well, that's something that we should be also talking about over in this committee," and this is just a better way to coordinate that. And then, as we just did, the GETAC chair will appoint an executive committee to appoint the committee members, and the committee is the chair of that committee, the GETAC chair, and then the 2 council members. And we're going to develop an SOP to address that appointment process. What are the qualifications? Are there any conflicts of interest? What is the expertise of value of that member to the committee? And then are we making sure that we're covering rural, frontier, and urban correctly? The decision-making process within the committee will be an attempt to seek to achieve a consensus at the committee level on the issues that require a vote before submitting them to the full council. So many people have limited budgets. They want to come here, and we hear time and time again that by the time they show up for the quarterly meeting in Austin, a vote is taken because it's been discussed at other committee meetings elsewhere, and it's the first time they've been able to have an opportunity to do input. So it can be discussed at many different committee meetings, but at the quarterly meeting, the committee will discuss it again and take their vote at that meeting to bring it to the council for further consideration. So as it says at the very bottom, it says committees can address the issues at interim meetings, and committee votes on the recommendations will be done at the quarterly meetings. And we think that will address the stakeholders' concerns of making sure that they have input at the time that it's voted on. So as we've heard as a council, is that the chairs don't want the committees working on things that the council doesn't want them working on. At the same token, we need to be aware as a council of the issues that are out there. So by changing, as we develop these SOPs or these rules for how the committees operate and work with the council, we believe we'll be able to better coordinate those topics of interest. Does council have any comments that they wish to add? So what the process will ultimately look like is the council will charge the committee with discussing whatever the topic is. The topic will be discussed within the committee just as it always has been. The committee will, for example, if they met this week, will discuss it, take a vote on what they're going to ask the council to consider in November. So they'll come to the microphone and instead of recapping all the discussions that were held in the committee, say, these were the charges that the committee was given. This is what our recommendation to you to take a final vote on in November if necessary. And also, these topics came up during our committee meeting. How do you want us to handle them? The other way that can happen is issues or topics can come directly to the chair. It doesn't have to be done exactly that way at the quarterly meetings. They can also come to me and we can decide then. We have an upcoming topic. We know there's 3 committees that need to talk about it. We can go ahead and get that ball rolling. The next item is regarding, we have a proposal for schedules. And I think, do you have the slide for that? While they're looking for that, I'll go ahead and explain. The council has 2 proposals for the stakeholders to consider that have to do with the scheduling of the meetings. And essentially, the meetings are condensed down to a Thursday, Friday meeting. Both schedules start with a meeting of this council, committee chairs and anyone else. There it is. That's proposal 1. On day 1, at 1 o'clock, the council will convene, make sure the committee chairs exchange information with committee chairs, lay out what's going to get accomplished over the next 2 days, and then finish with a meeting at the end of day 2 to get everything together to figure out what's going to go on the next agenda. So this is proposal 1, and this is, I'm not sure what you want to call this, the consecutive meeting proposal. And then proposal 2 is what we'll call the overlapping schedule. And so we're going to decide which schedule that we're going to select in the November meeting. So today we're not going to take any comment on it. It's going to be published on the DISH's website. We're going to have the next 90 days or however it is between now and November 12th, whenever we meet again. And then we will decide then based on stakeholder input. So you'll need to contact a council member and let them know which schedule looks better or works better for you. We realize as a council that there's some people that may want to go to every single committee meeting, and so obviously the consecutive one works that way, but there's also many committees that finish early, and you could get out of one committee and move over into the next one with the overlapping schedule. So these are the 2 proposals. We'll take comments on it in November and make a final decision. Now, the other issue is that Department of State Health Services already has contracts for meetings and meeting days and meeting spaces. So the recommendation we will be making to them in November may not go into effect until 2014 or late 2013, something like that.
Correct.
Okay.
All right, can I ask one question?
Sure.
For clarification. the meeting times are assigned, is that correct? These would be, so in other words, EMS would meet day one each time in that time slot.
Yes, I believe that's what
That,
we
I think
decided.
that was the
Right.
discussion.
Mhm. And I remember the discussion was the disaster committee usually lasts longer than that, so that they're on the end of it, so if they wanted to extend past that time, that could be accomplished on this proposal. Council wish to add any comments?
Does it have to be one or the other? Could we do one day consecutive and one day overlapping? And could we change that from month to month or quarter to quarter? And do you not want me to bring that up now?
No.
I think, as they say, this has been cussed and discussed. We need to pull the trigger and come down to these two proposals and keep one. Of course, that doesn't mean as part of continuous process improvement, we can't look at different things, but we're really wanting to get stakeholder input on which of these two works best.
It'll be up by noon today.
The public comment will be at the November GETAC meeting. But what we're looking for is, for example, I had 24 people call me and they prefer 18 to 6, they prefer proposal 1 or whatever. Provide that comment just so we have some you can, and basically there's two ways to publicly comment. One, contact a council member individually, or two, in November during the public comment period before we choose one, comment at that time. And again, I think this council wants to move to this 2-day format. There are many who can afford to be here starting Tuesday afternoon and going all the way through Friday afternoon, but there's many more that cannot and would love to. Basically, this involves one hotel night stay. That's why we started it on a Thursday afternoon. Everybody that needs to can fly in. Everybody that wants to go as many committee meetings as possible could come in on a Thursday morning and then catch most of them until the final GETAC council meeting on Friday afternoon, if they were flying or driving. So again, in the interest of time, when we have public comment period later, I'd like for everyone to just take a few days to digest this before making comment back, and we will take public comment either individually or at the meeting in November.
Vance, I may have zoned out and not heard it if you said it. Did you, on the first day of the GETAC meeting, that's when the department would give all their reports, is that correct?
Yes, thank you. I did not mention that. The other purpose of the council meeting at 1 o'clock on day 1 is then all of the reports that DSHS staff has been giving to all the committees individually can be given at one time, so they can all be heard by many, instead of having the staff have to repeat the same thing over and over going to each committee meeting. That was another process improvement. So as we transition into this, we will need the chairs to, from this point forward, to identify what specifically they're working on, which I think they gave very good reports today. And then for November, we will get a status point of where those things are and then determine what other things we need the committees to work on for the February meeting. And I think we've already sort of begun that transition here because as we went through each committee, there's probably one thing from 4 or 5 different committees that need to be placed on the agenda for discussion in November. So at this point, I'll take any comments from any council members regarding any of the strategic plan components.
If I may, I would like to give a little bit of track history as to how we came up with the 2 choices. I think that it's important to understand, just like Jane made the comment that the redundancy for her staff, as well as I'm sure she feels like a broken record by the end of the meetings at each committee giving the same report. The thought process was that people who go to every meeting also feel like that they've heard it before. So that was one of the things that we felt like the efficiency could be put in place. I'll tell you on the staggered schedule, it was an attempt to be able to get an extra 30 minutes in the committee meetings because your travel time and your time away is important. So with the consecutive meetings, you'll notice that they're reduced down to 50 minutes. It's important to also note, though, that may be adequate because you don't have the redundancy at the beginning of every meeting. In the staggered approach, you're able to get an extra 30 minutes where you wouldn't in the consecutive approach. So you might keep that in mind as far as the business going forward, being able to have more discussions. Maybe it would alleviate some of the angst with people who felt like that decisions were being made at remote locations and they would have to kind of chase the committee in order to weigh in. So those are some of the methods to the madness. I know that it's not a one-size-fits-all, but I'll welcome any phone calls or emails. I won't take any packages, but that we really weren't trying to ostracize anybody, so I don't want anyone to go away thinking, wow, I don't like 1 or 2, how about 3? Well, I think it gets us towards a more efficient approach. So,
I just want to add one thing that Ryan just mentioned too, and is that I know that from committee to committee, it seems like committees always meet at a different time every time. And sometimes that's very difficult when you're trying to travel. So for this approach, especially on option 2, proposal 2, we had some set times, trying to figure out when that committee would meet. So if those are the ones that you always attend or have interest in, it would be the same time every time, and it would be easier for you to plan. Certainly, I think there's a little flexibility there if we need to move one forward the other. I know some committees like meeting early, some like meeting late, but as the council met at retreat, there was a lot of time and a lot of effort put into this to try to make it better for you. So I'll just reiterate what Ryan said, is that please let us know which one of these that you like, and if there's some minor changes we need to make this better for you, just let us know.
Unless there's other council comments, Dr. Stewart?
No, I was gonna say, so I would like to sort of just clarify that I think we need, obviously, stakeholder input on these changes. And so the process is at the next GETAC meeting, that's the time to, in other words, you're basically we're putting this out there for people to digest and then get stakeholder input with respect to how they feel about the options and about the proposed changes.
Yes, and they're welcome to contact a council member individually between now and then for their ideas, suggestions, input, as well as at that meeting make public comment.
I'm going to ask too if they would do that by email or in writing, just so that it's not, 12 people talked to me when maybe 12 people didn't. So if we can just get you to take a moment to just email or write it down or give it to us so that we have something concrete and it's not just hearsay.
And please do not shotgun email the entire council at once. We run into possible open meetings conflicts that way. So pick your favorite council member and send your email or letter to them. And there are council members, not just the chair, so I know I can tell what they're looking like. But anyway, again, we have spent tremendous amount of time trying to do what's best for everyone on the committees and on the stakeholders. It's change. I won't repeat my favorite saying about change. But at the same time, really the information is still out there. The people providing input and the stakeholders, it's still there. It's just a little bit different way of coordinating the process. That's it. All right, is there any other comment on the strategic plan? Okay, we'll move on to item 5, which is a status update of revisions to the current Department of State Health Services EMS trauma rules, published in Title 25 of the Texas Administrative Code, Chapter 157.
Well, I managed not to put the schematic on here. We're just going to have to wing this. I had a schematic that I was going to show you the number of committee meetings that we've had in the last year where the rule has actually been discussed. It's some 63 different committees meetings where this rule has been discussed. The majority of those meetings were for EMS and trauma systems. Obviously, we asked trauma systems to do a lot of work, so I just wanted to give you a sense of how much involvement the committees and the stakeholders have had in this process. And I want to thank everybody that's participated. It was a huge, huge undertaking. And with that said, and as I told you in my report, we've had considerable staff turnover this summer. So it has pushed back our timeline to getting you a draft. I take full responsibility for that, but there's not a whole lot I can do about it at this point in time. We are shooting to have that good draft done by January the 15th. So from that date, we're working backwards, my staff and I, to work through all of the comments and get it into a draft format that we can bring back to the chairs and the committees. One of the discussions that I had with Ryan about this process was to give the committee chairs the opportunities to sit down with us prior to having our general session and go through it sort of line by line with the committee chairs, which we've added that into our plan. As far as when that will happen, I can't tell you. The thing that kind of mucks up the works here is the legislative session starts in January. If it is at all possible for us to get this done sooner than January 15th, we're going to do everything that we can to do so. But pretty much with me and Maxie and Emily, you're looking at the group that's doing it. So with everything else that's gone on this summer and having some staff challenges, that kind of got pushed to the back burner. And I apologize to you and to the stakeholder group because I know that they're interested in seeing the draft come forward. It does not change the plan to have the combined meeting with all of the committees and so that we can come together and go through it line by line. People can ask questions about why was that language not accepted. That's one of the things that we're preparing as we're doing this. Each suggestion that came from the committee on language that we are incorporating or not, we're providing feedback as to why we either accepted or declined to input that language. So we want to have that ready for our joint meeting and also the meeting with the chairs so that everybody understands why their suggestions were not included in the rule. Any questions?
I just wanted to clarify what, train jumped the track there, hold on. What you're saying is that all of the rule recommendations that came in for 157
Right.
will be analyzed by your staff with reasons why they cannot move forward with that recommendation, and then you're going to have a meeting with the committee chairs to explain that, and then an additional meeting later for everyone to come in and see that. Is that correct?
Correct.
Okay. So there'll be two opportunities, first committee chairs and then everyone to see where their recommendations stand, basically.
Correct.
Okay.
And that's really only the start, because, you know, it still has to go through you guys as a recommendation for a packet. There's going to be opportunity for public comment there. It has to go to the council. I mean, there's a long process to get input.
One of the challenges that we found is that trying to, for instance, for the designation rule, we had comments coming from trauma systems. We also had comments that came from pediatric committee. And then we have DSHS comments. So we have this 125 has orange for pediatrics, green for trauma systems, and blue for DSHS. So we have incorporated everybody's comments in it. And so that's what we're going to bring back to the entire group, so everybody can see all of the comments that came in, and then we'll have it, what was accepted and what was not. And so what comes back to the committees and will come to you guys will not be that color-coded document. It will be the document that will say, this was the existing language, this is the new language. Okay.
Any questions from council for Director Guerrero? Okay, seeing none, we'll move into general public comment. If anybody has anything they would like to comment on, please come to the microphone and state your name loudly, please.
Hello, good morning. I'm G.K. Sprinkle with the Texas Ambulance Association. At our last board meeting, we adopted a list of 5 priorities to look at for the legislative session. And it's something we wanted to share with GETAC because we're interested in feedback you might have. We'll be possibly drafting pieces of legislation or looking at other things revolving these priorities, and wanted to kind of let you know what we were looking at. Dudley mentioned that the Medicaid crossover issue has caused a great deal of problems with ambulance providers, and we'll be looking at ways to restore that money, maybe pieces of legislation that would do that. We're looking at trying to initiate what the HHSC and members of the legislature have already made comments on, which is to move all the Medicaid rates for all providers to Medicare rates, and we're going to be looking at that to see how that would work. There is a problem for ambulance providers in managed care, which has been expanded throughout the state in terms of being on networks of managed care entities and how much of the Medicaid rate managed care entities are paying, and we're looking at legislation to ensure that it's 100% for ambulance providers. We're also looking at direct pay of ambulance bills from both auto and health insurance, and changing the definition of advanced life support in the law. Now, you might think this is just a very weird thing to do, but apparently the state has looked at that definition in terms of what the state would pay for advanced life support based on that definition, when that definition was actually not put in the law to have anything to do with Medicaid reimbursement. It would just simply clarify what is in rule for Medicare reimbursement for advanced life service by tweaking the definition of advanced life service, advanced life support within the statute that sets up how providers are licensed. Thank you for your time.
Thank you. Microphone's still open for general public comment.
Good morning. Lori Lefevers with Grayson College in Denison, Texas. In 2010, the Education Committee was charged or requested from DISHES to revise the Education and Training Manual. And that task was completed, and the Education Committee had submitted the Education and Training Manual back to DISHES for posting to the website. And in February, a second submission to Phil Lockwood was made so that we could have that resource available on the website. Understanding that the coordinator course that's coming in November will need a resource, I would ask that we consider having that most accurate or most up-to-date resource, especially because the new manual addresses accreditation. Thank you.
Thank you. We will take additional general public comment, but we're cheering. It's getting a little difficult to hear back here, so do you have a comment, Jim?
I know that that document was submitted twice, and I think we are requesting at least some feedback on that document, whether things we put in there were correct or good, or and would like to see some of that document used for the coordinated course that is coming up in November, or if part of that document needs to come back to us for revision.
We're still open for general public comment at this time. Going once, twice. I'll close the general public comment. Timely. Thank you. We will take a moment to pause and reflect. I had no idea that our strategic plan would be so warmly received. Thank you. Yeah. We're going to try to work through this as they get louder. All right, payback one day. All right. I have several different items for the agenda for next time. One from cardiac care, one from education, one from medical directors, one from pediatric, and one from air medical. And I will get with those chairs and clarify what that will be and work with Director Guerrero.
We just need one emergency.
All right, I'll take any comments from the council. Oh, sure, now they get quiet. Okay. If there's no other comments from, I'm sorry, Maxie.
I did neglect to include that 157.32 accreditation rule was effective yesterday.
Okay. Thank you. All right, seeing no other council members' comments, then we will adjourn the meeting at, I guess it's about 11:30. Thank you. Respect and love on our journey.